Your patient hasn't eaten in 3 days, they're on ventilator, sedated, can't swallow, can't even think about food. But here's the thing, their body is still burning calories, it's still breaking down muscle, it's still needing nutrients to heal. So, how do you feed someone who can't eat? That's what we're talking about today, nutritional therapy in critical care. Hi, I'm Tochi, nursing student getting ready for my fourth critical care exam, and today we're breaking down everything you need to know about feeding ICU patients. And the next 25 to 40 minutes, we're covering why nutrition matters in critical illness, the difference between tube feeding and IV nutrition, how to place and manage feeding tube, complications to watch for, and what you do when things go wrong. No boring lectures, no complicated medical terms, just simple explanations that will help you understand how to keep your patient nourished while they eat. Let's go. Nourish while they heal. Let's go. Okay. First question. Why does nutrition even matter in ICU? Think about it like this. Your body is like a car. Even when the car is packed, it's not moving, it's not going anywhere, it's still using energy. The battery is running, systems are on. That's the same thing with our body. Even when you're sedated on a ventilator, completely still, your body is healing wounds, it's fighting infection, it's maintaining organ function, it's keeping your heart beating and your lungs working. And all of that requires fuel, calories, protein, nutrients. Here's what happens if we don't feed critically ill patients. One, muscle wasting. Their body breaks down muscle for energy, including the respiratory muscle, which makes weaning from ventilator even harder. Then also their heart muscle. Yes, it also breaks down their heart muscle for energy. So, number two, poor wound healing. The body can't repair tissue without protein. Surgical incisions don't heal, pressure ulcers develop. Number three, weakening immune system. You can't fight infections when they have a weakening immune system. They have longer ICU stays, they have higher mortality. Four, longer recovery. Because the weak, malnourished patients, it takes months to recover. So, yes, the role in critical care. All critically ill patients are assumed to be at a nutritional risk. That means if your patient can't eat, you find another way to get nutrients into them within 24 to 48 hours of admission, and that's where enteral and parenteral nutritions come in. All right, let's break down the two main ways to feed ICU patients who can eat. Option one, enteral nutrition, that's the tube feeding. Option two, parenteral nutrition, that's your IV nutrition. Now I'm gonna make it simple. Enteral nutrition, feeding through the gut. We put a tube down the nose that goes directly into the stomach or intestine, and then we pump liquid nutrition through it. The GI tract is still working, we're just bypassing the mouth, and then we're also bypassing the esophagus and swallowing. Parenteral nutrition, that's the feeding through the bloodstream. We put nutrient directly into the veins through an IV. The GI tract is not involved at all. Which one is better? Well, enteral nutrition is always preferred if possible. Why? One, it's more natural because it uses your GI tract like it's supposed to be used. Two, lower risk of infection, there's no central line needed. Three, is cheaper. 4, it maintains the gut barrier function. It prevents bacteria from leaking out of system or of intestine into the bloodstream. 5, we have better immune function. We only use parenteral nutrition, that's the IV feeding, when the gut is not working. So, when do we use IV nutrition? Well, if the patient has bowel obstruction, their gut is blocked, if they have severe vomiting or diarrhea that won't stop, if they have or if they need surgery and there will be NPO, NPA is nothing by mouth for more than a week. Patient is severely malnourished and gut can't absorb enough. So the rule is if the gut works, use it. Now let's talk about how do we tube feed? How do we do tube feeding? Well, tube feeding, let's break it down simply. There are two main types based on how long the patient needs it. There's the short term, which is less than 4 weeks, that's basically a month. We use a tube through the nose. The three options are nasogastric tube. That means it goes through the nose, down the esophagus into the stomach. This is the most common one. It is used if the stomach is working normally. Now we have nasoduodenal tube, which goes through the nose, down the esophagus, past the stomach into the duodenum. That's the first part of the small intestine. And nasogingival tube is goes through the nose all the way to the jejunum. That's the middle part of the small intestine. Basically, this is where you need to your A&P will help you anatomy and physiology. Okay, why do we bypass the stomach? If a patient has risk of vomiting and aspiration, gastric emptying problems, pancreatitis, that's the stomach. We need to let the stomach rest. So we're going to use the option where we bypass the stomach. Now there's long term, more than 4 weeks. We put a tube directly through the skin into the GI tract. Remember the first one, every even though you're doing everything, you're going through the nose. But the second one, you're just going directly through the skin into the GI tract. So there are two options. There's the PEG tube. Also, the full name is percutaneous endoscopic gastrostomy. Yeah, the tube goes through the abdominal wall directly into the stomach and is done with the endoscopy. That's a camera down the throat. It's like a just really minimal invasive type of surgeries, and it heals in place, so there's no nose tube to deal with. Genjunostomy tube as the tube goes through the abdominal wall into the jejunum, and this is for patients who can't use stomach. Now, to recap, short term nose tube, NG, ND, NG. Long term direct tube through the skin, PEG tube, J tube. Now, here's the critical nursing part. How do you know the tube is in the right place? Because if you pump formula into the lungs instead of the stomach, what do you think is going to happen to that patient? Process it. Well, you're going to die. So here's what we do. Step one, we want to do X-ray confirmation. Yes, you're gonna also always ossicate, but we're not gonna depend on that. If you ossicate, yes, but we're not giving no food, no meds, nothing. You do your X-ray confirmation first. After placement, always get chest X-ray. Never, ever start feeding until X-ray confirms placement. Step two, you want to check the pH of the aspiration. If it's a gastric content, remember anything from the stomach is acidic. So we're expecting our pH to be less than 5, more acidic. Remember, your normal pH is 7.35 to 7.45. So if it's acidic, that's something less than 5. It's more acidic. If it's intestinal contents, that's the pH will be greater than 6. And then if it's respiratory contents, the pH is going to be greater than 7. Step 3, you want to measure the tube length. You want to mark the tube at nose with a marker or tape, and then you document the measurement. You check before every feeding, did the tube move? So like, I think the most common ones we use 66, 70, around 65 to 70 range. So you mark it, and then it's like right here with the tape at the tube. So when you tape it down to the patient nose, and then if it moves, you know. Okay. Never just blow air into the tube and listen for the whoosh sound. That's not reliable. It's not evidence-based practice. You always want to confirm with the X-ray first. Now, all right, so we have the tube in place. Now, what do we actually put through the tube? We put tube feeding formulas. Think of this like meal replacement shake, but it's complete nutrition. Now, there are many types of formula. We're going to be talking about standard formula. It's 1 calorie per ml. So if a patient should take 300 ml, that's 300 calories. It contains protein, carbs, fats, vitamins, minerals. It looks like thin mixing, like tan beige color. Yeah, most patients get this one, and then there's the specialized formulas. They're like three types of specialized formula. We have the elemental. Elemental is pre-digest nutrients. It's easier to absorb, and then it's for patients with gut problem. And then we have high protein. It's extra protein for wound healing, muscle preservation for trauma, burns, and surgery patients. And then we have fiber enriched one, which is basically to help prevent diarrhea. How do we give it? Well, there are two methods. There's the continuous feeding and intermittent feeding. Continuous feeding is formula that runs through the pump 24 hours a day, like or 16 to 20 hours. It's depending on doctor's order. It's a slower, steady rate because the patient is it's continuously infusing, and it's better tolerated. It's used for small bowel feeding like the duodenum and the jejunum. Then intermittent feeding is formula given in meals every 4 to 6 hours. It's usually 250 to 400 ml over 30 to 60 minutes. It's more like normal eating pattern. It's only used for stomach feeding, not small bowel. Um, Yeah, it's a critical nursing point. Always check gastric residual before giving intermittent feeding or every 4 to 6 hours with continuous feeding. Gastric residual is basically when you go through and you drop with the syringe, with that big syringe, and drop and just see the residual, gastric residual. If residual is more than 250 to 500, you always want to check your facility policy, hold the feeding. Why? Because this means the stomach is full, and if you add more, patients might vomit and aspirate. Trust me, we do not want the patient aspirating. Now, you want to put, but here's the thing, if the tube is in the small intestine, not the stomach, you don't need to check residual. So if it's in the duodenum and the jejunum, you don't need to check residual. You don't need to do gastric residual. That is only when it's in the stomach. Why? Because small intestine does not hold large volumes. Checking residual would collapse the intestine. Okay, that's the basic of administration. Now let's talk what can go wrong. All right, complications. This is where nursing care really matters. Complication one, aspiration. This is the big one. Formula gets into the lungs. The signs that has happened, it's sudden coughing. All of a sudden the patient start coughing, respiratory distress, decreased oxygen saturation, crackles in lung, fever. And how do we prevent this? Well, we want to keep head of bed elevated, well, 30 to 45 degree during feeding, and for 30 to 60 minutes after. You also want to verify the placement before every feeding. You want to check gastric residuals. You want to make sure you don't overfeed patients. You want to suction mouth and nose as needed. Well, you want to suction as needed. If aspiration happens, stop feeding immediately. Call provider. Prepare for possible chest X-ray and antibiotics to prevent infection. Complication two, tube obstruction. That's when the tube is clogged or kinked. Yeah, I've seen a king tube. Think of it like a straw with dried milk shake in it. It gets clogged. Or think of it like inside the patient, it's like gets twisted and you can't push down anything. Nothing is going down to the patient. How do we prevent this? You want to flush the tube with 30 ml of water before feeding, after feeding, before medications, after medications, and every 4 hours during continuous feeding. Now, the reason why you want to do it before and after is to check, okay, the patient is okay, the line is still open before you do the feeding. And then the reason why you want to do it after is basically like flushing it down. Like when you eat, do you drink water? Yes, exactly. So that's basically why we flush. And also to make sure it's still open and not clogged. Now, if the tube does clog, you want to try flushing with warm water. So, if the tube does clog, try flushing with warm water. Sometimes pancreatic enzymes mixed with sodium bicarbonate can dissolve the clog, but often that NG tube needs to be replaced. Now, complication three, diarrhea. This is super common with tube feeding. Causes formula is running too fast, formula is too concentrated, medications, antibiotics especially. Oh yeah, antibiotics they cause it, and then C. diff infection. It's always consider this when a patient is that they're having diarrhea. Always consider all of this. It could be a cause. Now, what do? Slow down the rate, dilute the formula if it's too concentrated, switch to fiber enriched formula if the patient is having diarrhea, and you want to check for C. diff. You want to send two sample to the lab, and they'll give you back the thing. Complication four is nausea, vomiting, cramping. Now, signs the patient is not tolerating the feeding is what to look for is patient is complaining of nausea, eye gastric residual, vomiting, abdominal distension, like their belly looks swollen and upset bowel sound. What you do is you stop the feeding, you check residual, you assess abdomen, you call provider. Complication five is dumping syndrome. This happens when formula enters small intestine too fast. It causes sudden drop in blood pressure. The patient is profusely sweating. The patient has nausea. The patient is nauseous. The patient has diarrhea. It's more common with jejunal feeding. The prevention is to run formula slowly, because remember, the ones at the jejunum and duodenum at the small intestine basically is the continuous feeding. So you want to make sure you run formula slowly. You want to start at the slow rate, like 10 to 20 ml per hour, and you want to increase gradually as prescribed by the doctor. Complication 6 is hyperglycemia, that's high blood sugar. The tube feeding has a lot of carbs. Blood sugar can spike. Monitor blood glucose every 6 hours initially. You may need insulin coverage because uh, those food formula, they come often high in sugar to give you the nutrients you need. Complication 7, electrolyte imbalances. We want to watch for hypokalemia, that's the low potassium, hypophosphatemia, that's low phosphate, and hypomagnesemia, that's low magnesium. You want to check their labs regularly, and you want to replace as needed. And here is one more, refeeding syndrome. This happens when you feed someone who has been starved for a long time. It's when nutrition starts, electrolyte shifts into the cells rapidly. This causes severe hypophosphatemia, cardiac arrhythmias, respiratory failure, seizure, death. That's why we start slowly with malnourished patients. We don't go full feeding rates on day one. We want to monitor labs closely for the first 3 to 5 days. Real quick, how do we give medication through feeding tube? Never just crush pills and dump them in. No, we want to do it the right way. Step one, you want to consult pharmacy. Some medication can't be crushed, as your Enteral coated pills. Some of them just, some meds are just not meant to be crushed. Some interact with the tube feeding formula, and pharmacists can provide liquid form of this medication. Step two, you want to stop the feeding. You want to turn off pump 15 to 30 minutes before medication. Step three, you want to flush with 30 ml water. Step four, you want to give medication, one medication at a time. Liquid form is best. If crushing pill mixed with 15 to 30 ml water first. Step five, you want to flush with 30 ml water between each medication. So step six, you want to flush 30 ml water after last medication. Step 7, wait 30 to 60 minutes before restarting the feeding, or before you restart feeding. Do not mix medications together. Do not give medications with formula. They can interact and clog the tube, and then you have to do it all over again. It's not fun for the patient. It's not so fun for you. So keep it simple. Water, medication, water, next medication, water, finish the medication, then water, and then you give it 30 to 60 minutes before you will continue feeding. Now, quick overview of IV nutrition, TPN and PPN. Parenteral nutrition, that's the nutrient goes directly into the bloodstream. There are two types, the TPN. TPN is total parenteral nutrition. It goes through central line, that's a large vein, like subclavian or jugular vein. It's hypotonic. That means the TPN is very concentrated. It provides 100% of nutrition needed and is used for weeks to months. Now, PPN is peripheral. Peripheral, basically your midline. Peripheral parental nutrition. It goes to the peripheral IV, that's the midline, the AC, antecubital vein. And isotonic is less concentrated. It provides partial nutrition, usually combined with some oral or enteral. Is used for a short term, like for like a few days to a week. Now, TPN contains amino acids, which is the protein we need, dextrose, which is carbs and sugar, lipids, which is fats, electrolytes, which we all need, vitamins, and trace elements. It's literally a bag of liquid nutrition hanging on an IV pole. Now, nursing care for TPN complications. Complication one is infection. Central line is a direct path into the bloodstream. You want to monitor for fever, you want to monitor for chills, you want to monitor for elevated white blood counts. You want to change dressing per protocol. Usually every 7 days or when it looks solid, you have to change dressing. It's central line is a dedicated line for TPN only. So you do not push meds, you do not push IV fluids through that line. Complication two is hyperglycemia, high blood sugar. TPN has tons of sugar. Yes, it does. You want to check blood sugar every 6 hours, and the patient might need to be on insulin drip, even though they are not diabetic. So complication three is electrolyte imbalances. You want to check labs daily initially, then you adjust TPN composition as needed. You composition four is refeeding syndrome, same with as with the feeding with the tube feeding. You want to start slowly with malnourished patients. Bottom line with TPN, it works but it's risky. We use it when we have to, but enteral nutrition is always safer. Now, let's talk about your nursing responsibilities. Daily assessments, you want to check their weight, same time, same skills, same outfits every day. 1 kg is 1 liter fluid. Are they gaining? Are they losing? Or are they stable? Intake and output, you want to document every ml. How much formula is going in, how much urine is coming out, are they vomiting, are they having diarrhea? You want to also check for bowel sounds. You always want to oxycate all four quadrants, starting from your right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. Basically, you go into the end shape. Um, Are they present? Do you hear bowel sounds? Is it hyperactive? Hyperactive might indicate the patient has diarrhea. Is it absent? That might indicate ileus. You want to hold feeding. Abdomen, you want to look at it. You always want to inspect first, then you palpate. Is it soft? Is it distended? Is it tender? Is there any rigidity? Tolerance, is the patient tolerating feeding? Is there basically no nausea, vomiting, diarrhea, cramping? Residual within normal limits? Blood sugar is controlled? Labs, we want to check that regularly. We're checking our abdomen, pre-abdomen, as the protein status, your electrolytes, blood glucose, and liver function. If on TPN, you want to check for liver function. Now, your job is to catch problems early before they become complications. All right, let's wrap this up. Here's what you need to remember. One, all critically ill patients are at nutritional risk. You want to start feeding within 24 to 48 hours of admission. Two, enteral nutrition, that's tube feeding, is always preferred over parenteral nutrition, which is IV feeding, if the gut works. Three, you want to confirm tube placement with X-ray before first feeding, before any meds. You want to check the tube position before every feeding after that. That is if you use the NG tube. If you go through the NASA way. Four, you want to flush tube with 30 ml water before and after feeding, before and after medications. Number five, you want to check your gastric residuals for stomach feeding, not small bowel. You don't do it for small bowel like jejunum and duodenum, but you do it for stomach. You want to hold feeding if residual is over 250 to 500 ml. 6, you want to keep head of bed elevated 30 to 45 degrees. Even though you need to change them, you need to pause the feeding. Don't put their head all the way flat. Quickly change them, of course, with the help of someone, and put them back in the position they were, and then you resume feeding. Um, Also, you do this to prevent aspiration. Number 7, you want to watch for complication, aspiration, clogged tube, diarrhea, high blood sugar, electrolyte imbalance. Number 8, TPN is high risk for infection. Has its own dedicated line through this central line, subclavian or jugular. Sterile technique, it must be done. It's a sterile procedure, and you have to monitor closely. And that is nutritional therapy simplified. If this helped you, hit that subscribe button. I'm posting nursing videos every week to help you study and succeed. Next week, we are covering a topic. I don't know yet. It's a surprise for me too. Drop your questions in the comments. What part of nutritional therapy is still confusing? Remember, you're doing amazing. Keep studying, keep learning, and don't forget, you got this. Bye.